Treatments for gynecological cancer have changed in my lifetime, no doubt about that, which is encouraging because certainly when I was training there were perhaps one, maybe two treatments for things like ovarian cancer. I would say we've now got at least half a dozen, if not a dozen, potential treatments for the same type of tumour. We're also recognising that a label of ovarian cancer probably isn't ovarian cancer. Firstly, the vast majority probably come from the fallopian tube. Secondly, there are obviously subsections of them and they respond in different ways, and the heterogeneity, as there is in all cancers, is quite evident. Fortunately, there's lots of development in both pharmaceuticals and in other approaches, so not just sort of cytotoxic medication, but PARP inhibitors, so targeted therapies, which seem to be applicable not just to the so-called BRCA mutational group. So this is a group of around 15 to 20% of ovarian or fallopian tube cancer patients who have inherited a BRCA genetic mutation or have one as part of their tumour development, and they respond very well to this group of drugs called PARP inhibitors, which are known to have a double hit and apoptotic effect because of the way that DNA is repaired. So certainly that's been a vast step forward. We've also discovered that that's applicable not just to the BRCA mutant population, but to a lesser extent to the BRCA wild type population. So we need now to work on what that may be combined with, or how we can use that best in order to help a patient actually not maybe be cured, but certainly have disease control for lengthier periods of time. And I think we are slowly achieving that. It's borne out by some of the CRUK statistics, which suggests that the 5-year survival of ovarian cancer or fallopian tube cancer 10 or 12 years ago was around 33%, it's perhaps now at 43%. Sadly, the cure, if you like, no cancer at all, is still only around 15%, so we haven't altered that, and I think we've also got to change perhaps public's perception to suggest that some of these cancers are not going to be cured, but if we can control them in the long term, then it becomes more like a chronic disease, and that may be something that is acceptable to patients. Taking Peter Johnson's last plenary talk, that's not really acceptable. I entirely agree, but sometimes we've got to compromise on some of these things. And if we don't start looking at some of the disease control agents, we may not identify the one or two that could potentially cure things. So it's got a long way to go. And there are setbacks, and I'm not sure immunotherapy is going to be quite the thing that it has been in melanoma and lung cancer. We don't have quite so much mutational burden. We have a lot of heterogeneity, but we don't have quite so much of the mutational burden in ovarian cancer. And we've got to look at ways of targeting which populations might respond better to that sort of treatment, or using that in combinations, and where is the best point to actually introduce them. So lots to do. And early days as far as the immunotherapy is concerned.